When evaluating heart disease risk, which metric is best? LDL, non-HDL cholesterol, which includes LDL, but also VLDL, lipoprotein A, and IDL, ApoB, or something else? To address this question, today's guest is Dr. Elias Bjornsson, whose research group recently published a paper showing that a simple-to-use equation that includes ApoB, triglycerides, or VLDL, and lipoprotein A is a better metric for evaluating heart disease risk relative to LDL, non-HDL cholesterol, and ApoB independently alone. So with that in mind, welcome, Elias, and let's get into the presentation.
Great. So thank you for that, Michael. My name is Elias Bjornsson. I'm a researcher. I'm a cardiovascular researcher here based in Sweden, University of Gothenburg. My area of expertise is, well, cardiovascular disease in general, but in particular lipoproteins and atherogenic ApoB containing lipoproteins is my special interest. So I'm going to be talking about our recent paper today, where we introduce a new concept called risk-weighted ApoB. But before I do that, I'll give a brief introduction on why we study ApoB containing lipoproteins at all to begin with. So the reason is that they are causal factors in atherosclerosis. So unfortunately, the typical scenario for many people today is that at some point in our lives, we develop atherosclerosis. If you're typically your 20s, 30s, your arteries look good and clean, no plaques. But due to the presence of ApoB containing lipoproteins and other enhancing factors, you can say, we tend to develop atherosclerosis. So what happens is that these lipoproteins get stuck in the artery wall, they get retained, they get modified, some bad stuff happens, which leads to the accumulation of or the formation of plaque. Now, atherosclerosis in and of itself is, you could argue, not a problem. What we worry about is the eventual risk of cardiovascular events, so myocardial infarctions and strokes and such. And that typically happens in your maybe 60s, 70s. Then you have accumulated enough atherosclerosis to begin to experience events. So, of course, if we lower ApoB containing lipoproteins early in life, we will halt this progress and lower your risk of having cardiovascular events later in life. So that's the reason why we study them. And what kinds of atherogenic lipoproteins are there? Well, there are three kinds. You can simplify it as. So the most famous one is the one to the left. It's called a low-density lipoprotein, LDL. If you go to your doctor, you typically check your LDL cholesterol. So as you can understand, this is a type of lipoprotein that contains cholesterol. It's not the only thing that they contain. They contain minor bioactive lipids and some triglycerides and other things and other proteins. But they also contain one structural apoprotein called ApoB. So that's why we focus on this term ApoB always. So ApoB is sort of the defining feature of an LDL particle. It's exactly one ApoB per lipoprotein particle. But it's not the only, LDL is not the only ApoB containing lipoprotein. So the other one, if we move to that one in the middle, has a complicated name. I don't know if your audience or how familiar you are with ApoB containing lipoproteins, but Lp(a) is another ApoB containing lipoprotein. If you look at it, it looks very similar to a regular LDL particle, but in addition, to ApoB contains another protein called ApoA. Very complicated nomenclature here, but it also contains other features such as oxidized phospholipids and other things that may distinguish it from an irregular LDL particle. But that's the other type. So the third fundamental type of ApoB-containing lipoprotein is called a TRL, triglyceride-rich lipoprotein. So if you listen to the name, you can understand that it contains more triglycerides than the other types of lipoproteins. It actually contains more cholesterol per particle as well compared to LDL. But it is a little larger also in size typically. It becomes eventually an LDL particles when it gets delipidated. But it is fundamentally a different type of lipoprotein in this stage. So we have LDL, we have Lp(a), we have triglyceride-rich lipoproteins. They all contain ApoB, and they all contain exactly one ApoB per lipoprotein particles. So those are the three types. Why do we need to bother? Why don't we just measure ApoB, and then we have measured everything, right? Because your ApoB is your LDL plus TRL plus Lp(a) particle number. Then that's it. We can't do anything else to measure your risk. Well, the problem is that thanks to our research and many other types of research in this area, we now begin to understand that not all ApoB-containing lipoproteins are created equal in terms of atherogenic risk. So TRLs are probably somewhere in the ballpark of 4 to 5 times more atherogenic per individual lipoprotein particle than an LDL. And the same goes for Lp(a). Maybe even a little bit more, maybe 6 to 7 times more atherogenic than an LDL particle. Now, that doesn't mean that you can ignore LDL, because LDL is the most numerous particle of them all. But if you want to estimate risk or have some measure of lipoprotein-associated risk, could be good to take this into account. So that's where the concept of risk-weighted ApoB emerges. So this was an idea from my colleague Michaela Rehman. She developed a version of a risk-weighted ApoB measure a couple of years ago, which she published in this brief report, which included weighting Lp(a) and LDL. So that's one step in the right direction, but it did ignore triglyceride-rich lipoproteins. So that's why she contacted us, my research group, and said, what about making the best risk-weighted ApoB that takes into account the full spectrum of ApoB-containing lipoproteins? So that's where we then move into this recent paper. So that was the idea. This paper was published very recently in the European Heart Journal, and it's called Risk-Weighted ApoB, a novel summary metric outperforming traditional lipid biomarkers in predicting coronary heart disease. So the rationale for even developing this to begin with is to capture not only all of the number of ApoB particles, but the risk relating to all of the number of ApoB containing lipoproteins. So we can sort of compare it to traditional lipid risk markers. So what are those traditional lipid risk markers? Well, it's LDL cholesterol, it's non-HDL cholesterol, and it's ApoB. So comparing to those. So if we start with LDL cholesterol as a measure, what's good and what's bad about it? Well, what's good about it, most people forget this, that it's actually a measure of it's a measure of cholesterol content, yes, not particle number. So it's the cholesterol content of your regular LDLs plus your Lp(a) cholesterol. So in the LDL-C assay, it will capture your Lp(a), the cholesterol content of Lp(a) as well, which is actually a good thing if you want to predict risk. But it has the drawback of ignoring triglyceride-rich lipoproteins. So that's why people argue that, well, non-HDL cholesterol, or you can call it ApoB cholesterol if you like, should be a better risk marker in this sense. Why? Well, it takes into account your TRL cholesterol as well. So non-HDL cholesterol or ApoB cholesterol is just your LDL cholesterol plus your Lp(a) cholesterol plus your TRL cholesterol. But if you realize quickly that it's just the cholesterol content of the particle, it's not the particle number, and it may be better to have the particle number if you want to know the risk. So that's why people argue that you should measure ApoB. So ApoB is the total particle number of LDL plus TRL plus Lp(a). And why is that not then the ultimate risk marker? It would be the ultimate risk marker if LDLs and TRLs and Lp(a) per unit ApoB were equally atherogenic. Then it would be the ultimate risk marker. But if that's not the case, then there is a need to introduce this risk-weighted ApoB concept if you want to capture the full risk. So the idea really is that risk-weighted ApoB takes into account the particle number, but it weights the ApoB according to the atherogenicity of the individual components. So that's the rationale and idea. If we dig a little bit deeper into the paper, here's figure 1 of the paper. As I said, the idea and rationale is to derive this risk-weighted ApoB, and we derive it based on our previous Mendelian randomization-based studies. So we don't do any further optimization here. We just say that we have previously shown that TRLs are 4 to 5 times more atherogenic, Lp(a) are 6 to 7 times more atherogenic. Those are the factors that we stick with. And then we, based on this, make a risk-weighted ApoB equation, which I will show you briefly soon. But if we just apply it then to UK Biobank, and if I can draw your attention to plot C here, here we just have, if we plot the ApoB of all participants in the UK Biobank, and we plot on the y-axis their risk-weighted ApoB, if it were the case that everyone just falls on the exact same line, so there's no difference in ApoB and risk-weighted ApoB, there would be no need to calculate risk-weighted ApoB because there would be no people with high or low or vice versa, no discordant, if you wish, people. But as you can see that there are some people that have quite a lot higher risk-weighted ApoB than what is suggested by their ApoB level. And vice versa, there are some people who have quite a bit lower risk-weighted ApoB than their ApoB level. So there may be room for improvement. So the equation that we derived, you could have derived lots of different versions of this equation, but our criteria was that it shouldn't involve any sort of exotic measures in terms of, for example, you could have used NMR methodology or something like that, but it's not really widely available. So we wanted to have something that clinicians can actually apply. So the individual component that goes into the calculation is your plasma triglyceride level, it's your Lp(a) level, and it's your ApoB level. So you cannot just take your standard lipid panel and calculate risk-weighted ApoB, because standard lipid panel unfortunately does not include Lp(a) and ApoB. However, this is probably about to change. Many people are starting to measure their Lp(a) levels and their ApoB levels. So if you know it and you have your plasma triglycerides as well, then it's okay. Then you can calculate your risk-weighted ApoB. And if you don't want to do it by pen and paper, you can also use the web app that we developed. So it's on riskweighted.apob.com. So what about the prediction accuracy? Is it any better than the traditional lipid risk markers? Well, as you can see here, on the y-axis, we use something called the concordance index. It's basically just a measure of how well the measure captures your risk of coronary heart disease events. And as we know from previous literature, we know that LDL cholesterol should be a slight inferior choice. It doesn't say, I mean, it's still a good risk measure, don't get me wrong, but among these lipid risk measures, it's the least accurate. And I think everyone agrees on that, and there are no surprises there. And the reason is, of course, that it fails to include triglyceride lipoproteins. So in that sense, non-HDL cholesterol is a little bit better. So as a risk marker, lipid risk marker, non-HDL cholesterol is pretty good. And ApoB, there's been a lot of debate which measure of non-HDL-C or ApoB is the best to use. There are actually some reasons why you could prefer non-HDL-C, but empirically, most of the literature seems to support ApoB as the superior risk measure, and we also see that in our study that ApoB tends to outperform non-HDL-C. And then in red we have the new risk-weighted ApoB measure. So you can see that it is an improvement above and beyond non-HDL-C and ApoB. How much of an improvement? Well, we can go to this slide and sort of ask the question, how many people are re-ranked if you rank them on ApoB or risk-weighted ApoB? So I know Sankey diagrams are a bit complicated. Some people love them, some people hate them, but I'll just walk you through it briefly. So what we did here was that we simply ranked people in UK Biobank based on which quintile of ApoB they're in, 1, 2, 3, 4, 5. And then we asked the question, how many people in the top quintile, because that's really the kind of people we're interested in capturing, right? The ones with the highest lipid associated risk. How many in the top quintile are rearranged between ApoB and risk-weighted ApoB? And the ones that are concordant, that are not rearranged, they are both high in terms of ApoB and risk-weighted ApoB. Those are the concordant individuals at the top. 2/3 are concordant. So for them, risk-weighted ApoB doesn't seem to add much. They're still in the top. But for about 1/3 or a bit more than 1/3 of individuals are actually those individuals, their ApoB says one thing and risk-weighted ApoB says another thing. So then which do you trust? So for about 1/3 of individuals, they come from lower quintiles of ApoB. And you can see that there are actually even individuals from the bottom quintile of ApoB that are upranked all the way up to the top of risk-weighted ApoB. But of course, most of them come from the 4th quintile. There's sort of this high-ish value, but not really super high. So a lot of people of them, what are their characteristics? Well, unsurprisingly, their characteristics is that they have a combination of either high Lp(a) and or high plasma triglyceride levels. But the proof in the pudding is that are they actually at higher cardiovascular risk? Do we do the correct thing by up ranking them? And if you look at the color code for each of these bands, you can see that the more red you see, the higher the coronary heart disease event risk. So we see actually that we do a better job at identifying risk in these individuals with lowish to not very high ApoB, but still high cardiovascular risk driven by hypertriglyceridemia or high Lp(a), which makes their risk-weighted ApoB high. So we conclude that it's not a trivial amount of individuals actually that are re-ranked. So another type of area where risk-weighted ApoB may be particularly good is in terms of residual risk identification. So what do I mean by that? Well, people who are already on lipid-lowering therapy, statins, for example, they have lowered their LDL and therefore lowered their ApoB quite a lot. So in that particular situation, it may be particularly difficult to risk stratify them based on, well, particularly LDL cholesterol, but also non-HDL cholesterol and ApoB sort of breaks down a little bit. It makes your job at risk stratifying them even harder. And that's possibly where risk-weighted ApoB would do a better job. And I think these data are unpublished, but empirically we do seem to be seeing that trend that if you rank people on risk-weighted ApoB who are already on a statin, you do a little better risk stratification job. But I think we're going to do more work in this particular area. So keep an eye out for that. Now, lastly, just to plug the risk-weighted ApoB calculator a little bit and show you some examples. This was more a theoretical. Let's now dig into some nitty-gritty examples where ApoB and risk-weighted ApoB can agree or disagree. You can go to the calculator and play around with it. Here are, for example, a hypothetical person with plasma triglycerides of 150 milligram per deciliter. That's quite common. It's not optimal, but it's quite common. What is good is that this person has low Lp(a), so no problem there, and a very, very average ApoB level of 100 milligram per deciliter. So for this particular phenotype, ApoB and risk-weighted ApoB pretty tells you the same story, right? Both are around 100. No disagreement. Many people are like this. So then risk-weighted ApoB will not add very much. So you can also play around with how much of your estimated particle proportions. So you see that most of your ApoB containing lipoproteins for this type of phenotype is LDL or LDLs, 90% or so. In terms of risk contribution, we can see that LDL contributes most to lipid-associated risk in this individual. So if you want to lower, you would probably lower LDL in this individual. So that's an example where ApoB and risk-weighted ApoB agrees. Where does it not agree? Well, let's take this hypothetical person, for example. So again, the same triglyceride level, pretty typical. But here we see high Lp(a), 100 milligram per deciliter. Now, ApoB will, of course, be a little bit elevated because of the high Lp(a), but not very elevated. So if you look at only ApoB for this individual, it looks quite unremarkable. So ApoB of 110, but risk-weighted ApoB of almost 150. So that's very high. What is driving that? Well, it's of course your high Lp(a) level. Still, if you look at the particle proportions for this individual, most of your ApoB containing lipoprotein particles, 80% or so, will still be LDL, of course. But quite a lot of the risk contribution for this individual will be driven by Lp(a). This doesn't mean that you cannot lower risk by lowering any other thing than Lp(a). You could, of course, lower LDL in this individual, and you would improve risk. You could do it. You could improve risk substantially for this individual. But if you look at the risk contribution, sort of half your lipid-associated risk is LDL driven in this individual. So you could work with that half. Now here's another example. Plasma triglyceride 500. Wow, that's very high. No good. What was good is that, well, at least you have low Lp(a). Of course, your ApoB will be elevated depending on how much LDL you have. But in this example, you could typically see this situation where you have a very high TG, but still not very high ApoB. So again, this is sort of the same, the equivalent scenario of high Lp(a), but high triglycerides instead. Yeah, ApoB looks okay. Risk-weighted ApoB does not look okay. Your particle proportion still is 75% or so will be your LDL. So you could lower that. Your risk contribution in this setting will be very much driven by your pronounced hypertriglyceridemia. So whether or not if you can lower your triglyceride levels, that would be very good for this individual. Of course, you can always also lower LDL for this individual. It would be beneficial either way. Lp(a) lowering for this individual will not do any good, of course. And the last example I have here is that's this sort of mixed phenotype. Now we're talking triglycerides of 250, Lp(a) of 50 milligram per deciliter. Both are high, not extraordinarily high, but both are on the high side. ApoB is on the high side, but not extremely high. So again, this would be sort of an additional combined way to get you to a quite high, alarmingly high risk-weighted ApoB level. And now in this situation, as always, you have a lot of LDL particles still, but risk contribution will be about half is still LDL. So lowering LDL for this individual would, again, be a good idea. You could do that. You could lower risk. If you can work with getting your triglyceride levels down, that would be great. In future, if we have Lp(a) lowering, that could also be an add-on or an option. So depending on your risk profile and where you want to go, how do you get there, sort of thing. But this is another way to reach high risk-weighted ApoB level where your ApoB is still not extremely high. So those are a few examples. You can play around with the calculator if you like. The take-homes today are that never forget ApoB containing lipoproteins. They are important causal factors for atherosclerotic cardiovascular disease. If you lower them, you will get less atherosclerotic cardiovascular disease, less atherosclerosis. That's for sure. But how do you appreciate all your ApoB related risk? Well, this risk-weighted ApoB is a new way that summarizes all your ApoB related risk into one number. Then, of course, you can always look at your individual components as well, but it's sort of a summary metric that could serve a useful clinical purpose, and it does outperform the traditional lipid measures we do have at our disposal at the moment, namely LDL cholesterol, non-HDL cholesterol, and ApoB. With that, I thank you for your attention.
Thanks, Elias. That was great. I have so many questions, and it's like I have an explosion in my head of so many questions at once. So I got to make sure I go through them, all of them. So first, in addition to thanking you for presenting and being here and answering all the questions, I have more thanks because I think it's in part because of Mahela. Am I saying her name right? Michaela?
Michaela, yeah.
Michaela, yeah. So I think I came across her paper, and that's what got me thinking about the whole idea of it isn't just so I've been tracking ApoB in it, for a while, and um, with the idea, obviously, that quote unquote lower is better. And I have questions surrounding that too, that we can hopefully go through in a minute. But my lipoprotein A has always been at the high end of the reference range or higher. And this idea that, LP little a is genetic and inflexible and you can't do anything, well, maybe pharmacologically. And there are a few studies on diet, maybe, high dose niacin, nicotinic acid, or other stuff, which I've tried and have with some efficacy, but liver enzymes go crazy. So anyway, the long story short is when I came across Mihaly's paper, it got me thinking, okay, my ApoB is low, but if I'm only going to stay in this boat of, well, my ApoB is 60 milligrams per deciliter, I'm good. In the context of my lipoprotein A being 90 nanomolar, uh, so something didn't sit right. So when Michaela's
Yeah.
paper came across, it was like, I'm going to start tracking. And this was before your paper came out, just more recently, where now it's this beautiful metric of making my life so much easier. Because if I'm tracking ways to try to lower LP little a, I'd have to increase LDL while keeping ApoB the same, which is more difficult than actually tracking a metric like what you developed. So anyway, a grateful thanks, because this makes my life and many others' life much easier, because it's now very easy to use metrics. So I know that you guys in UK Biobank, so higher was worse for risk-weighted ApoB in terms of CHD risk, right? But in terms of what's optimal, like if you had to say a number for what's optimal, and I don't mean, and I get that probably most of the client populations that you'd be thinking about would be higher risk, but the people, for myself and others on this channel, the health and longevity space, we're generally not interested in triglycerides of 150. And not that I'm knocking that, but it's the other side of that distribution where how low is too low. And even, I know this is a long diatribe, but if you have an ApoB of 60 and LP little a is 10 nanomolar and triglycerides are say 45 milligrams per deciliter, just arbitrary numbers for now. Within that context, if those numbers are a little bit higher, say 70 for ApoB, a little bit higher TGs, even though that may play out with delay in cardiovascular disease for decades relative to the average population, if you live long enough, that small difference, 10 milligrams per deciliter, may play out in atherosclerosis. So the idea of what's optimal, if you had to put a target number on risk-weighted ApoB, and maybe this is something you're going to look at in future studies, whether it's all-cause mortality risk or validating in even more cohorts besides the cohorts that you use in the study, the MESA and other cohorts. So what would you put as what's optimal for, say, triglycerides, LP little a, and risk-weighted ApoB in terms of the lowest possible risk, CHD and all-cause mortality risk?
Yeah, that's a very good question. It depends on your ambition level, I would say. If your ambition level is high and you want to really avoid developing atherosclerosis for many, many decades, if you're that type of person, I would aim for a risk weight that would be of, you can't go really too low, but I would say below 50 or 40 to 50 in that range, then it will require quite a lot of time to even develop atherosclerosis. So most people will, if they're between 40 and 50 in risk-weighted ApoB their entire life, they will probably not have a chance to develop substantial amounts of atherosclerosis, which will delay their risk of cardiovascular events. So they will probably end up dying from other reasons than cardiovascular disease. So 40 to 50 range, I personally I'm at 40 roughly, so I'm happy being at 40 milligram per deciliter for many decades forward. My plan is to keep it that way. Now, how do you get to 40 or 50? That's very difficult for a lot of people. No, very few people are at those kind of low levels. So typically, you would say, like if you're a little bit less, less, less ambitious, let's put it like that, and you can accept some cardiovascular risk. 60, 70, 80, that's the okay range. Many people above 80 will develop atherosclerosis, just a question when and how much. You see what I mean? So it's not a hard line, but it's this little bit of a gray zone flowing thing. And it also, we know that this depends on your genetic susceptibility to ApoB-containing lipoproteins. So some people have a vessel wall that is more vulnerable to the exposure to ApoB-containing lipoproteins. If you're that kind of person, you need to actually lower your you need to be more ambitious to avoid cardiovascular disease. So if you're that kind of individual, you would probably go for the lower range, 40 to 50. If you happen to be lucky enough to be one of those individuals that have a resistant artery wall, you can probably take 70, 80, 90, something like that. But most people today are at 90, 100, 110. And that means that they will inevitably in their 50s for sure for men, and in their 60s for women, they will develop substantial amounts of coronary atherosclerosis. That does not mean that everyone will experience a cardiovascular event. So that's the next hurdle to get over. But you're in the range and you have enough plaque to be at risk of an event. So I hope that answers your question. You would have to decide what's my personal risk preference and how do I get there? How do I achieve my goal of being as low as I want to be? And you asked also the individual components. Like a lot of people carry more triglycerides, more triglyceride lipoproteins than that. I think that's an underappreciated component of your risk. So my rule of thumb is that any value below 1 millimole per liter plasma TG, something like that, would be 90 milligram per deciliter. Then you're in on the right side of the equation, so to speak. Most people are not that. So most people typically maybe 1.5, 1.6, 1.7 millimole per liter. That's very typical today in most societies. Would be 150 milligram per deciliter, something like that. So they do carry this extra remnant or triglyceride lipoprotein related risk, which you have room to improve. Many people have room to improve there. For LDL, many people have lots of room to improve, I would say. So typically what we see, like a typical value here in Sweden, for example, and in UK Biobank, that's 3.5 millimole per liter of LDL cholesterol. So most people could reduce that by 50%, and that will do them a lot of good. I mean, of course, it's a personal preference. Not anyone wants to lower, I mean, either dietary ways to lower that but let's be honest, most people would need to have some sort of preventive therapy to get you down to the 1.8 millimole per liter range in LDL-C. Not everyone is willing to do that, but if you are willing to do that, most people have a lot of room to improve in your LDL department. And Lp(a), of course, that's the special thing. It's very, very highly genetically driven. At the moment, we don't have specific therapies for that. That is very much under development. If you're one of those unlucky people that have high Lp(a), so typically it's about 15 to 20% of the population who have high Lp(a), then you would want to know that, and you also the level. If you have just maybe you have like a little bit borderline high Lp(a), just above what would be classified as high. If you're that kind of individual, you can sort of mitigate a lot of that risk by working down your LDL levels. If you're in the extreme end, I would say you do everything you can now, but hopefully at some not too distant future, we have pharmacologic agents for that as well.
So first of all, 40 for risk-rated ApoB in your case is amazing. Is that pharmacologically, or is that just diet and exercise and leanness?
Yeah, no, I do take a statin. So I happen to have low Lp(a), so that's just lucky. I do exercise quite a lot, and my triglyceride levels are typically 0.5, 0.6, something like that. And then I take a statin. I take rosuvastatin, 5 milligrams, to get my LDL down to 1.8.
So what would be your LDL if you weren't taking the statin? Do you know what it was before that?
Yeah, untreated, my LDL-C was hovering around 3.3 to 3.5.
Interesting. So have you experimented? So if you looked at using diet alone to lower LDL, it's great that you have low LP little a. That's neat. You cross that variable off the list because there's going to be a genetic range where you can get it probably, can you go from 90 nanomolar to 10 nanomolar? I don't know, maybe from 90 to 60, so that you start off with low LP little a helps you a lot in this equation. But LDL is very easy to reduce. Now, granted, you said it, I think the key word is if you're motivated or ambitious. But so for example, within 2 weeks, LDL and ApoB, which is most of it coming from LDL, RCTs of very high fiber diets and reducing saturated fat intake. I'm sure you know these. The Jenkins, a high fruit and vegetable. Yeah, yeah. So within 2 weeks, ApoB, I mean, it was like, I don't know, 20% down, and that's just one example, a very
Yeah.
high fiber diet. So eh, do you look at risk reward versus doing it versus diet versus statins? I mean, granted, there's a lot of debate on statins, you know, uh, not reducing all-cause mortality risk. Some studies show it does. Meta-analyses, maybe not, even within the context of lower CHD risk. So what are your thoughts on, like, if for people who can cut their LDL and risk-weighted ApoB using diet and lifestyle versus using it pharmacologically in terms of long-term risk, not just CHD, but all-cause mortality risk too?
Mm. Well, what I would say is that if you're only focused on lowering LDL, if that's your only goal, uh, diet will probably, you would have to either follow it quite strictly to get huge LDL-C reductions. If you look at the studies uh, by Professor David Jenkins, the portfolio diet, for example, those kind of studies, if I recall correctly, you can lower it. You typically see 25-30% LDL-C reductions in those types of studies. If you're that kind of person and you know that you will adhere to this diet for several decades, I say go for it. That's great, and it probably has also other benefits. So it probably lowers your risk of developing hypertension and obesity and everything, insulin resistance, and all that goes along with that. So anything in that department probably has other sort of positive pleiotropic effects, if you put it that way. Pragmatically, I know that it's a very difficult thing to do for many people. So it's not as a scalable solution. So in that sense, and it's also not a huge effect size on only LDL-C. So if you wanna, if you compare that by taking a low dose statin, really, you can reduce LDL-C by 40-50%, which is very good, and it's compared to dieting, it's easy to follow. So, yeah, and you touched also on safety. Some people are uncomfortable with the safety profile of statins. That's, I would say, largely unfounded. If you look at there was a recent meta-analysis on statin side effects. There are side effects by statins for sure, but they're not very dangerous. And we know that a large component of the side effects related to muscle symptoms are probably nocebo effects, or they have been shown to be nocebo effects demonstrably. So a lot of the side effects are can be mitigated by trying different statin, trying different dose, adding ezetimibe, something like that. So you can play around with that sort of thing. And you don't forget that most people who take statin, they don't develop any side effects. So they can take it for many years without any problem. So if you're that kind of person, which is the typical case, then that's a great option, I would say. So long story short, but I would say that I don't want to prescribe anything to anyone in particular. I'm just saying that if there are these different tools in the toolbox, you can sort of figure out what's your preferred option, where do I want to go, what's my ambition level, what do I have to do only diet-wise to get there? Am I prepared to do that? If I'm not prepared to do that, would I add a little bit of a mini dose statin, a baby statin, and explore those options and look at it from a objective standpoint and not rule things out. So that's the kind of decision making I'm all for.
Yeah, very practical. So just to push back on the diet a little bit. So it may not be as hard as people think to achieve very low LDL. So I'm not on a statin, and my LDL is consistently in the 60 to 80 range, depending on, how much I cut sat fat, and how much I increase my fiber intake. Granted, my fiber intake is super physiological and from whole foods, 80, 85 grams per day, which most people don't do yet. Maybe someday. But interestingly, and maybe, I'm not sure if you're aware of this research, but I was looking into mushrooms and their ergothioneine content. I don't know if you're familiar with ergothioneine and its ability to impact lifespan in animal models, and a whole bunch of other studies relating it to health and cognition, et cetera. So in some of the studies that I was looking at, they measured lovastatin in mushrooms, which was a surprise to me because if you go to your favorite LLM or AI chatbot and ask it for foods that contain statins, you'll get, red yeast rice, which has a chemical that's similar, chemically identical to lovastatin, but isn't lovastatin. But many common mushrooms, including white button mushrooms, which most people think are inferior relative to like the more exotic maitake or shiitake, or go down the list, have a significant amount of lovastatin. And if you eat a pretty big dose of mushrooms, 300 grams, which most people don't eat any vegetables, so I know 300 grams of mushrooms is going to be a problem, but not for me. You get about 10 milligrams of lovastatin. So is that the reason why I've got relatively low LDL? Because I'm eating 700 grams of mushrooms a couple days a week? Uh, anyway, I just wanted to throw that out there, that it is possible to do it by diet. And granted, you wouldn't have to worry about potential. I hear you on the meta-analyses and side effects, but I've seen people, blood test data, people taking statins, and their creatinine levels are perplexingly a bit higher than they should be, and they've got liver enzymes that are reaching the high end of the reference range. And is that because of the statin? Is that the dose? And there's a lot of variables that you got to sort out. Is there muscle damage and CoQ10 depletion? Whereas people are eating mushrooms, I'm not that I'm just to push back. I think there are other options too, but I hear you on people who don't want to change diet and are at risk and have high, ApoB and all the other stuff. You don't have a choice but to give them statins, right? They're not going to change their diet. So for people who there, and I think there's a pretty significant segment of the population, for better or worse, that think that lipoproteins, LDL in general, are not causal in terms of heart disease. So what would your thoughts be to that?
Well, it's hard to convince everyone, but if you look at the evidence, it's very clear. There are different lines of evidence when it comes to LDL in particular. I would say the evidence is very, very clear. So, of course, we have all the epidemiological evidence, but more importantly than that, we have two types of causal inference types of studies that are both positive, and those two types are randomized controlled trials, where we lower LDL and you can observe a lower cardiovascular risk for those who get the LDL lowering. And further on, there are different ways to lower LDL by using different types of pharmacological agents. So we have statins, we have ezetimibe, we have PCSK9 inhibitors, both monoclonal antibodies and siRNAs. And they all lower risk in proportion to the LDL lowering. And then in addition to that, I have worked a lot with the Mendelian randomization types of analysis, and I can tell you from firsthand experience that there is no way to get a result where LDL is not causally related to coronary heart disease events. It's as clear as anything in science. So no matter how you pick your genetic instruments, you can pick SNPs that are actually in the target of the statins, HMG-CoA reductase. If you pick SNPs in the LDL receptor, if you pick SNPs in the PCSK9 protein, or if you pick SNPs that just phenotypically lower LDL and doesn't seem to affect anything other than LDL, all of those situations, you see a cardiovascular risk reduction. So I would actually say that the case for Lp(a) and for triglyceride-rich lipoproteins are less strong than for LDL because we don't have the randomized control trial evidence for those yet. I mean, there are ongoing trials, and the Lp(a) Horizon trial will be one of the first trials that test the Lp(a) hypothesis within the context of a randomized control trial. We'll probably get those results this year, maybe April, May, something like that. So that will be interesting to follow. But on the genetic side, again, the Mendelian randomization types of analysis that me, ourselves, my group, and many other groups have done, they all point in the same direction. So particularly for Lp(a), it's very, very consistent and clear that all the genetic evidence will point, they do point to a causal effect on cardiovascular events, coronary heart disease events in particular, but also peripheral vascular disease and aortic valve stenosis. Then we, in addition to that, have data on coronary atherosclerosis. So we see that Lp(a) relates to higher prevalence of atherosclerosis, which is not the cardiovascular events, but the actual disease. So for me, it's one of those things that it's hard to find for LDL. It's hard to find something that is as consistently clear. So that puts anything in science is never 100% sure. So there's always room for a little bit of doubt, and you can argue in specific situations and depending on context and so on. But LDL, so for sure, one of the most clearest causal types of evidence we have in medicine today. Lp(a) and triglyceride-rich lipoproteins are not as clear. So there we have still room for particularly the randomized control trial evidence. But the genetic evidence is very clear for those. And I'll let everyone make their own conclusions, but I hope they make it unbiasedly. I know that a lot of people will have various types of issues with ApoB containing lipoproteins and LDL in particular, and statins. There are a lot of opinions out there, but I urge them to just look at the totality of the evidence.
Nice. So I think that statin trials, I think there's, even with a reduction in LDL, there's some outrageous number, maybe 50% or some percentage still end up with having a cardiovascular related event at a later date, even with very low LDL. So I don't know what the exact percentage is. So is it possible that because statins specifically lower LDL and not the more atherogenic lipoproteins, VLDL, lipoprotein A, that's a part of that story where if someone was taking a statin and, whatever the best medicine is going to end up being, whether it's the PSK, what is it, PSK9 and whatever meds can lower, if all of that was lowered, that would further reduce risk.
Yeah, so you're touching on this concept of residual risk. So just because you get a statin, let's say you have walked your life with high LDL for many decades, and now you want to turn the boat and you lower your LDL maybe from, let's say, 190 to 100 or something like that. And you do that for a few years. You still have the accumulated exposure of all your LDL exposure for your entire life. In addition to that, you have the exposure to the other ApoB related risk factors, so Lp(a) and triglyceride-rich lipoproteins, which you don't address by reducing LDL. Further, you don't reduce LDL to zero, so you reduce it to some extent. So you still have your residual lipid risk components will be LDL and triglyceride-rich lipoproteins and Lp(a) if you have high Lp(a). And in addition to the, you have residual risk from non-lipid associated residual risk. So you may have elevated blood pressure, for example. So that's the other causal factor. And in addition to that, you may have other enhancing factors such as insulin resistance. Maybe you smoke and maybe you're overweight and so on. So it's a sort of it's no surprise to me that there will for sure still be substantial residual risk, and most of your risk it can come from non-lipid sources or lipid sources, and we know we for sure have residual lipid associated risk, and in addition to that, you may have non-lipid associated residual risk. So you would have to lower LDL by a huge amount to make a huge dent. But the reason why some people then argue that, well, maybe you have lowered it too late in your life. So you could start a little bit early, and then you can really make a dent in your accumulated exposure. So that's sort of and you do see that genetically as well. So people who are blessed with genetically low ApoB levels, they experience a lifetime lowering of exposure lowering, and if that delta is big enough, then they will have very much lower cardiovascular risk.
Nice. So that raises a couple questions. I got to make sure I hit them all and not forget. But so total cholesterol, low in youth, peaks in midlife, starts to come down towards end of life. So it ties into what you're saying, where if you're able to maintain relatively low levels of ApoB or ApoB containing lipoproteins and the right distribution, low VLDL, low lipoprotein A, and keep that low indefinitely, then what you're saying is you'll keep your cumulative exposure low, maximally reducing your risk of atherosclerosis and CHD events. But the thing is, during aging, it peaks during midlife. And that's probably the reason why you see in some of these studies that haven't fully adjusted their models for, comorbidities that can impact the association for LDL or cholesterol with all-cause mortality risk, where people at midlife who have higher cholesterol have better survival relative to people who have lower cholesterol, because there are situations like liver disease and cancer, cachexia, cancer in general too, where LDL can be lower. So if the models aren't accounting for that, you could take someone who's got quote unquote high cholesterol and they have better survival than someone with lower cholesterol, but the models haven't accounted for those comorbidities. So my question here is, you've got another segment of the population where, and I'm not anti-keto or any diets, for me, it's all about biomarkers, but there is a segment of the population that is purposefully, whether they have dietary intolerances or whatever, their LDL is super high, their ApoB is super high, cut out carbs, but within that context, the other variables that you mentioned, HSCRP may be low waist to hip ratio, not overweight, good metabolic health, if they do have good metabolic health and they're measuring it. So what are your thoughts on, even though for me, what makes sense is cholesterol and ApoB is low in youth, keep it there. If your diet and your lifestyle is leading you to have higher levels of ApoB and lipoprotein, whether they're more atherogenic or not, you're on that aged phenotype, even if you've got low HSCRP. So that would be my take. But what would you, for someone who's not on that, for someone who's got higher ApoB, but they're metabolically healthy and they've got all the other bases checked, how would you consider, and I don't think there's any published data, but what would be your thoughts on that versus it's low. I'm not using pharmacological means to keep it low versus the other keto crowd where they've got a lot of the other boxes checked in terms of health.
Well, so depends on what your cardiovascular risk consists of. If you're metabolically healthy, you have low blood pressure, you don't smoke, you're not obese, you have all those other non-lipid associated risk factors optimized or in check, then your really only problem, first of all, you will have generally lower risk of cardiovascular events. So you will be on a better life path, regardless if you have what your lipid associated risk is. But if let's say you have all that optimized and dialed in, but you have ApoB of 150 and you have LDL cholesterol of 5 millimole per liter. There are these individuals, and we call them familial hypercholesterolemia, and they are typically metabolically healthy, but their only problem is that they have severely elevated LDL-driven risk in this case. What happens to them? Well, they do develop atherosclerosis rapidly, and they progress rapidly, and they typically, if left untreated, they will have cardiovascular events in their 40s and 50s. Nowadays, we have treatment options, so we can delay that nicely. But in that particular phenotype, you need to address the lipid-associated risk. If you are like most people on this like middle life trajectory where you look, your numbers and the blood pressure and the ApoB look good in your 20s and 30s maybe, but then they start to climb, so you have this typical pattern of an accelerated accumulated exposure type of thing, and it's not only the lipids, but it's a little bit of high blood pressure, a little bit of everything. How do you break that? How do you mitigate it? Well, if you were to lower your exposure at an early age, maybe in your 30s, 40s, if you know you're high already then, you break the curve, you lower it then, that will be a very good investment for yourself in your 60s and 70s, because then you have sort of shifted and delayed that whole plaque progression thing. So there are, of course, different ways to achieve the same end result. But if the end result is actual delaying of the process of atherosclerosis, this plaque progression curve that most people are on at some point in their life, if they want to break that and have very low or no plaque initiation and certainly no plaque progression, then you need to, as I said before, be ambitious. Then you need to, try and look for any ways you can do that, not rule anything out. If you have high blood pressure, lower your blood pressure. Do it by pharmacological means, do it by exercise. Lower your LDL by diet, lower your LDL by pharmacological means, and so on and so on. So, as I said earlier, there are a lot of different ways to the same end result. There are a lot of ways you can. There are a lot of tools in the toolbox to use if you don't want to be on this plaque progression race that a lot of people are on today.
So, all right. So if I heard that correctly, it's if your LDL and your ApoB and risk-weighted ApoB is low in youth, keep it there. Keep it there in conjunction with low blood, all the other factors that are involved. The blood pressure, inflammation, metabolic health. Keep it there. And for the people who are on the higher track, whether it's genetically familial hypercholesterolemia or on a very high fat, low carb diet, that would be potentially not optimal, because even people who are, I don't know, I haven't looked at the studies on familial hypercholesterolemia. You would obviously know better than me, but have they adjusted the models for HSCRP and BMI or body weight, waist to hip ratio, glucose? So even within the context of all of the quote unquote optimal other variables that are optimal, in conjunction with very high levels of total cholesterol, there's still an increased progression of relative to someone who's got lower with all of the other variables. Is that accurate?
Yeah. Well, it's accurate in the sense that you would say that the people who have genetically elevated LDLs, they typically don't have this sort of environmentally elevated LDL phenotype, which we could be more of a lifestyle-driven type of LDL, but they have something wrong in the LDL receptor. Metabolically, they're fine. Well, maybe fine, like they're like most people, but they're not like they haven't eaten their way into high LDL levels, if I put it that way. So there's nothing, no systematic metabolic changes that have produced a high LDL. It's just the LDL receptor that is broken. And then you have the corresponding very much elevated risk of cardiovascular disease. So that's why I say that the ApoB containing lipoproteins are sufficient to produce atherosclerosis, even in the absence of any other risk factors. If you have high LDL and nothing else, you can be perfect in any other way. Perfect, low CRP, low BMI, low blood pressure, no smoking. You will still get atherosclerosis if you have high enough ApoB. That perhaps cannot be said for all other risk factors. So the other risk factors are not, they may be more of an enhancing type of risk factor, if you see what I mean, the distinction. They're not the sufficient causal effect that the lipoproteins are, due to the nature of the lipoproteins themselves. It's the actual lipoproteins that get into the vessel wall, and that's the substrate for the plaque development. So that's sort of the necessary and sufficient substrate to develop atherosclerosis. And vice versa, if you have, let's say you have high blood pressure, but you lower your ApoB to 25, will you develop atherosclerosis? Well, maybe not. Even if you have high CRP, even if you have high blood pressure, even if you have high BMI, maybe you won't develop atherosclerosis because you can't, because the necessary substrate to develop atherosclerosis is gone. If you see what I mean.
Yeah, interesting. So I just had a couple of studies in mind where lipoprotein A associated, whether it was MACE or it was CHD, CVD-Risk. I don't remember which it was exactly, but for that study, it was people who had HSCRP less than 2 milligrams per liter versus greater than 2 milligrams per liter. For the quote unquote high LP little a group with quote unquote low, because to me, 2 milligrams per liter for HSCRP is still very high. It would be like 10x my data, which is nuts. But nonetheless, that low group had a significant difference in either MACE risk or CHD related events. So it ties into this story a bit. Well, other factors like HSCRP, even with relatively low LP little a, you get to a high enough level of inflammation with low LP little a, and still,
Yeah, no, but that's why I say that most of the risk factors it's completely expected that if you can take other risk factors like BMI, for example. There was a recent paper on BMI and LP(a), and you can see that the cardiovascular risk, if you have a very high BMI, is high, a very high Lp(a) is high, but the combination is even worse. So most of the risk factors are like this in combination with the lipoprotein associated risk. You may have this additive and maybe sometimes even synergistic effects. So that's why usually in lipid associated risk context, we always say that lipid associated risk should be viewed in the overall context of your overall cardiovascular risk factors. Because if you typically for Lp(a), for example, if you have high Lp(a), that can maybe increase your risk of cardiovascular events by 50%, say, sometimes 100% if you have high enough Lp(a). So if it doubles your risk and your absolute risk is 0.5%, your absolute risk will be 1% if you have high Lp(a). If it doubles your risk from 5%, it will increase your risk from 5 to 10% in absolute terms. So that's why the context matters so much for all cardiovascular risk factors, but not least the lipoproteins. Having said that, it's still an open question that if you get ApoB low enough, so you have baby levels of ApoB, let's say you have 20 milligrams per deciliter, you have virtually not perhaps the substrate to be can you even develop atherosclerosis? I think I just pose that as an open question because let's say you have 20 milligrams per deciliter ApoB and you have high CRP. Well, does that get you to atherosclerosis development? Maybe not. So maybe if you remove the necessary or the necessary substrate for atherosclerosis, you can get away with other risk factor in a way that you, in the FH scenario, you can never get away with high enough LDL, even if you're metabolically perfect in any other way.
So your bet would be, and not to rain on the keto parade, but your bet would be that's probably not going to be good long-term news for CHD risk.
Yeah, if I had to, I mean, it's still an empirical question, so which I do take it seriously, but from all other previous research, where do I put my money? I wouldn't risk it for myself to say that least. So even if I were in perfect metabolic health and I would go on a ketogenic diet and I would see my LDL level go up to 5, 6, 7, 8 millimole per liter, I would be very worried. I wouldn't be worried in a very short enough time frame, especially if I'm young. Let's say I'm 37, 38. Will I develop atherosclerosis even if I go on a ketogenic diet for 5 years? Well, probably not. It will not so much will happen in that time span. But if I'm on it until I'm 45, 55, 65, my bet is that will produce an immense amount of damage to your arteries. It will cause atherosclerosis development to be rapid. But it's still an empirical question, so we'll have to see that.
Yeah. So what's interesting about the low carb, high fat diets is that evolutionarily there are probably periods throughout evolution where hunter-gatherers were just killing animals like crazy and eating all the animals in the forest and eating no leaves or no carbohydrate contain or very little. You know what I mean? So it's like granted, their lifespans were generally shorter. And I don't know if that was because of atherosclerosis or not, but it's just interesting that, and I'm not anti-meat, I'm not anti-keto by no means. I care about, I'm agnostic with these things. Like I said, I follow the biomarkers, but as you mentioned, in the short term, I can see it, being an interesting approach. But, once you killed all the animals in the forest, you got to eat some leaves. I mean, you got to eat other stuff. Otherwise, right? So.
Yeah, I mean, like if you there are always room for debate on this sort of evolutionary types of theorizing about what we as humans used to eat. We probably ate quite diverse, but if you look at the subpopulations that do exist today that do live like hunter-gatherer types of situation, you have the Hadza people, the Tsimane people, and maybe some others. if you look at their plasma lipid levels, they look great. So they typically, and also in blood pressure, they have like perfect blood pressure their entire lifespan. So it's not like that ticking up situation where we see us happening. So they typically, their LDL levels, I believe the Hadza people, their LDL levels is pretty much half as much as most Western populations, and they're stable throughout their life. So they are at 1.8 millimole per liter roughly on a population level in their 20s, in their 30s, in their 50s, in their 60s, in the 70s. So there's something about whatever the environmental effects are. I mean, they eat a lot of fiber, and they certainly do not eat a ketogenic diet. The Hadza people in particular, but there's something about their total environmental exposure that makes their blood work look great. And if you look at their coronary arteries, they seem to be doing pretty good as well. So they're not on this plaque progression curve that most of us are on.
Yeah, the Hadza are a great example, so thanks for that. So when considering, okay, I get the lipoproteins as a causal factor in this equation, but, as you've mentioned, the inflammation, hsCRP, maybe other inflammatory markers, waist to hip ratio, glucose/HbA1c. Do you have plans to add to the risk-weighted ApoB, equation and try to get that Harold C, maybe 7.75, 0.8, 0.9?
Well, we don't have plans for that, but it's a purposeful plan not to include them. The reason is that I mean, you could include many other factors. You can include age and sex and BMI and HbA1c and CRP, IL-6. Maybe that would boost your concordance index or ROC, AUC values. But that's not really the purpose of the risk-weighted ApoB. So the purpose is to fully capture your lipid-associated risk. Then it's another job to put that lipid-associated risk into your overall cardiovascular risk context that I was mentioning earlier. And that you can probably do by other means of having predictive values. In Europe, we have the SCORE2 equation. In America, you have the PREVENT calculator or some other calculators, and you can probably expand and make some more advanced cardiovascular risk prediction models. Other than that, which includes X, Y, and Z. But if you want to quantify the lipid-associated risk and identify also the clinical have the clinical value of understanding your ApoB-related risk, it serves that purpose. And then for perfect prediction modeling, that's a different kind of clinical purpose, I think.
For the other models that you mentioned, I'm not familiar with the SCORE2 or the other one that you mentioned, though, but I don't think they include because risk-weighted ApoB is so new. Wouldn't those predicted models serve a better purpose or be more predictive if they included risk-weighted ApoB?
Well, it's a little bit of a debate on, at the moment, SCORE2 includes non-HDL cholesterol. So, of course, with Lp(a), there are these now guidelines where you have to sort of add, if you have high Lp(a), your overall cardiovascular risk category should be bumped up a little bit. So it's a little bit of an afterthought. It's not completely integrated into the risk engine as well, at least at this point. So there will, but for official SCORE2 guidelines, I don't see risk-weighted ApoB being incorporated anytime soon. It will be, as I said, a little bit of a secondarily included based on side criteria of having high Lp(a) and so on. So it will be baked into some extent. But I do agree that if you were to have the lipid risk component of the SCORE2 calculator be risk-weighted ApoB instead of non-HDL-C, yes, it would probably improve a little bit. But it's a very slow process of updating that risk algorithm.
So for the other variables, waist to hip ratio, like, do you have specific ideas of what those numbers should be? Like HbA1c, is it just less than 5.7, or would you aim even lower, like 5? Blood pressure 100/60, or is it 115/75? Like, do you have specific targets for the or are you completely focused on lipids, lipoproteins, and not necessarily the top of the other variables?
I'm not so knowledgeable about the other numbers and targets, what to hit. Of course, I have a rough idea, but my focus is on the lipids. I know the lipids best. As for blood pressure, I would obviously say that it's probably the case that 120 is anything above 120 is probably extra risk. So that's sort of probably the breaking point. I know a lot of people have complaints about having too high of an ambitious goal for blood pressure guidelines, because then if you put the target values low, like 130 maybe, well, that's half your population here in Sweden, for example. So then it becomes a situation which is, for pragmatic purposes, maybe not manageable in a primary care situation. But if you just reason from first principles of what is optimal, yes, then optimal values is probably a bit further down than the not so ambitious pragmatic target goals that you would have in your clinic. I know that's for sure for the lipids as well. I mean, here, if you go to a doctor and you get an LDL of really less than 5, it's considered normal, which is far from optimal. So there's different levels of normal, and you would say that if you want to be ambitious, you don't want to be normal. You want to be half normal.
Yeah, so it makes sense. So I'm getting back to the paper, and I noticed that in UK Biobank, when you were comparing risk-weighted ApoB against ApoB in terms of CHD risk, ApoB was actually significantly in UK Biobank, but not in the other cohorts. ApoB was inversely correlated or inversely associated with CHD risk, then I look for the model adjustments, which as I mentioned are essential to. But so I'm wondering, did you guys miss a couple of model adjustments that account? Because then that gets into that question of people are going to say, well, look, higher ApoB in UK Biobank is better for CHD risk. And even though you see, right? Because yeah, yeah, tell me.
Yeah, you were very, very astute in pointing that out. That was not the case in the other external validation course, but it was true in one iteration of the biobank set that we used. We actually did some other sensitivity analysis as well, where that was not the case. So it was just non-significant. The point estimate wasn't actually below. But in this, the final version, it was slightly below. That can be a little bit of a statistical artifact, because the average. This is quite difficult to explain for like a non-statistical audience, and please bear with me. But if you include a risk factor like LDL, for example, that is the LDL on average as a lipoprotein particle, it's on average less atherogenic. It's still atherogenic, but it's less than the average, because the average is a mix of LDL, TRL, and Lp(a). So if you put in those, if you put in risk-weighted ApoB and LDL, your LDL will actually statistically pick up that it will be a lowering from the median ApoB particle. So it will appear in a statistical sense as protective. So that kind of statistical thing can happen in these types of models. But I urge people not to over-interpret that little finding. The overall finding is that risk-weighted ApoB tends to include the ApoB risk and then some, which leaves ApoB not predictive anymore once you account for risk-weighted ApoB, which is the fuller picture. I think that's the correct interpretation.
Yeah, definitely. I didn't see it in the paper. I was hoping to see a nice, pretty picture of a dose response for risk-weighted ApoB versus CHD risk. Even though you put it in continue as a continuous variable. But did you see that in plotting the data where and I'm guessing the answer is going to be yes, but as low as physically possible was indeed the lowest CHD risk?
Well, we did plot the deciles of risk-weighted ApoB against the coronary heart disease event rate, just raw event rate, and yes, it's just the lower risk-weighted ApoB decile, the lower the risk, and the lowest decile isn't extremely low. I can't recall from the top of my head, but the lowest decile is probably around 60, 70, something like around that range. But interpretation, extrapolation from that sort of trend line, you can see that if you were to have people with even lower risk weight, that would be their risk would be even further reduced. There was no inclination that trend line would just stop. But having said that, of course, at some point, you could have a situation where you have people with non-lipid associated risk factors that I said earlier, blood pressure. So if you still have high blood pressure and you have risk-weighted ApoB of 50, yes, you could still experience cardiovascular events, which is blood pressure-driven events in that sense. And it also depends on the event definition. As you know, if you look at just myocardial infarctions, that could be a different story. But if you look at CVD events, which include strokes and other types of substrokes and stuff like that, that is more blood pressure driven. You would probably see that the curve sort of stops, and if you go at some point, you stop experiencing the myocardial infarctions, but you still have the strokes due to high elevated blood pressure and so on. So, but what I can say from the data we do have in UK Biobank is that the lower your risk-weighted ApoB, the lower your coronary heart disease event risk.
Interesting. So then that gets me into the idea of all-cause mortality risk. Did you look at risk-weighted ApoB versus all-cause mortality risk and not just CHD events? I mean, is that concordant where lower is better not just for CHD, but risk of death for all causes?
Well, we haven't looked at that. Typically, we tend to not look at all-cause mortality because it's such a broad event definition. My borderline is even should we even look at total ASCVD events? I typically just want to look at myocardial infarctions because that's the most relevant outcome measure. But of course, if you're interested in living longer, yeah, then you would be interested in looking at that. You can die from a lot of different sources. So it's one of those situations where if of 100 deaths, maybe if 5 of them are truly driven by the myocardial infarction event, and that's what you're lowering, you will lower that portion of those 100 events. So maybe if you lower that by 50%, you still have the 97.5% of all cause mortality events driven by other things present. So it's one of those things that it's a dilution factor thing. But if you really think that my aim of lowering ApoB is not to avoid a myocardial infarction, it's to live longer, then that's relevant. And my reading, I haven't personally looked into that so much, but my reading of the existing literature is that if you do lower your ApoB long enough, you will live longer. So if you do have a lifetime lowering of ApoB exposure, I think the cumulative reading of the evidence, the literature is that you would probably live a couple of years longer, something like that. Doesn't mean you will live forever, but it's not one of those cases. I know there was some press on. I can't remember if it was Dr. Sima Lotra or someone on X or Joe Rogan podcast or something recently. I haven't followed this very closely, but usually it pops up sometimes then and there that statins only lower your expected increase your life expected by a few days or something like that. But that's largely a misreading of the literature. If you twist and turn and triangulate a little bit, you would probably end up in a situation where if you, like me, take a statin from in your 30s and onwards, you probably expect to live 2-3 years longer, something like that. That's my best guess, at least. Not being very well versed in that type of literature, but I would put the honest estimate somewhere in that range.
I don't know what the magnitude of the lifespan increase would be or expected life expectancy increase would be. I haven't seen those studies published, but the study that comes to my mind, and I'm sure you're familiar with it, is the Amoris study. So it was like a 35-year follow-up where it supports what you're saying, where ApoB, granted, I wish they looked at risk-weighted ApoB because, as we know, that's the more informative measure, but lower was indeed better. The lower the ApoB, that was associated with lowest risk of death for all causes. What that translates into, so it's not just lower CHD and ASCVD and all of under the CVD umbrella. It's not just for the maximally lowering that. It was lower, absolutely lower. I mean, I have the trend line in my mind. I mean, it was almost like perfectly linear. And that's a 35-year follow-up. And a reason I like that study, and people are going to say you're cherry-picking studies, but that's not at all what I'm doing. It's, again, which goes back to, again, the adjustment variables, right? Accounting for reverse causation. And they went through the full gamut of all of the variables, including liver disease and cancer cachexia, to adjust for the association. So, but I don't know if that's 2 to 3 years. I don't know if that's 10 years. I haven't seen the life expectancy expected increase in relation to the all-cause mortality risk reduction. But all right, so I have another question too. So I've seen some pushback online, even from lipidologists, where the Mendelian randomization studies, even though they show a predicted risk of 6 to 7x more for lipoprotein A and 4 to 5x, as you mentioned, for VLDL versus LDL, how that actually translates into a risk, higher risk in terms of death from ASCVD related events. For example, the study I have in mind, it was, lowest CVD related events was like 16 nanomolar, 7 milligrams per deciliter. And I think the risk, CHD risk, was somewhere around 15% of the population. But then even for people who had very high levels of lipoprotein A, it was maybe 100 nanomolar or 200 nanomolar, 250, something very high, super high at LP little a. The percentage of the population that had a CVD event or a death from CVD was only about 30%. So I think when most people hear 6 to 7x or 4 to 5x, I think like a 6 to 7x increased risk of death from a CVD-related event. But in fact, it's maybe a twofold higher, which is still very high, or 20% higher. So how do you square that circle between and I made the 6-7, I made the 6-7. What an idiot I am. But you know what I'm saying? How do you square that circle between the genetically predicted risk? And I've actually seen, like I said, the lipidologists push back and they're like, is that really that high? How do you translate that into the real world?
Oh, it's quite easy actually. It's a numbers game. So you would have to just realize one thing, that even if they're 6 to 7 times more atherogenic per lipoprotein, they're much less abundant. So that's very simple. So if you have something that is very atherogenic but less abundant, that will not translate into extreme levels. It will not mean you're at 6-7 times higher risk of cardiovascular disease events. So if I just put the numbers into perspective, a typical person maybe have 2,000 nanomole per liter of LDL particle number. So 2,000. Even if you have very high Lp(a), let's say you have 200 nanomole per liter, you're still an order of magnitude lower in Lp(a) particle number than LDL particle number. And then it will only add so much. It will add, probably if you have in the top 1% of high Lp(a), your risk of a total atherosclerotic cardiovascular, your lifetime risk of ASCVD events, for example, it will probably go from, let's say, 10% to 20%, something like that.
You were saying about the 6 to 7x and 4 to 5x genetically predicted, and then if you generally those are lower, well, at least for Lp(a), it's lower, but if it's higher in some people, then how would that translate, that 6 to 7x genetically predicted risk, into an actual percentage of the population increase in terms of, now you have 30% deaths by CVD instead of 15%, which would be a twofold increase and not necessarily a 6 to 7x. How do you translate that?
Well, yeah, so as I said, it's a numbers game. Let's do the numbers. Just very overview first. Like if you have just a regular LDL particle number and you have high Lp(a), you typically still have 10 times as many LDL particles as you have Lp(a) particles. So if you do the math, then you could probably say that maybe half, if you have high enough Lp(a), maybe half your ApoB related risk would come from Lp(a), but still maybe half comes from LDL, and of course something from triglyceride lipoproteins as well. But it's not a situation where Lp(a) totally dwarfs your LDL risk. So Lp(a) tends to always add more or less substantial portion of risk on top of LDL. And I think empirically, if you look at the Lp(a) consensus paper, this typically translates not into several-fold higher risk of total lifetime cardiovascular disease events, ASCVD events, that is, but maybe 100%, like double. It can double your lifetime risk of cardiovascular events if you have high enough Lp(a). So maybe your lifetime risk goes from 10 to 20%. That can happen if you're maybe in the top 1 percentile of Lp(a). But typically high Lp(a) is defined as a group above 50 milligram per deciliter or 105 nanomole per liter. They, I would say, as a group, may have probably around 50% extra lifetime risk of coronary heart disease events. That's not nothing, but it's not everything either.
50 milligrams per deciliter for lipoprotein A is still pretty high. I mean, what percentage of the population has values that high?
Yeah, it depends on the population, but it's typically 20% of the population. So here in Sweden, it's around maybe 15% of the population. If in Asia, it can also be a little bit low like that. But 15 to 25% of the population has Lp(a) above 50 milligram per deciliter or 105 nanomole per liter. So it's about 1.5 billion people worldwide.
So this is a potentially random question, but why? I mean, what would be the evolutionary purpose, or what would be the purpose for Lp(a) relative to LDL that does not contain Lp(a)? I mean, why would 1/5 of the population have a way more atherogenic protein on its lipoproteins? Like it's got to serve some kind of purpose, no? Or is it just a defect in our evolution?
Yeah, it's a very good question, and no one has the answer. So this is often debated on scientific conferences. What's the purpose? Jokingly, we say the purpose is to create coronary heart disease, but clearly some other purpose has evolved. So people speculate that it can make you more resistant to blunt force trauma. Basically, it can make you heal a little bit faster. So if you're a population that has historically evolutionary been exposed to high levels of physical violence, then maybe Lp(a) could be advantageous. You could recover from that better. But that's a speculation, so nobody really knows. In evolution, it has occurred independently from each other. It has popped up in evolution, but it's not a universal thing that all species have Lp(a). We humans some of us do, and nobody knows really why.
I wonder if you take professional fighters, MMA, UFC, whatever it may be, if right, I wonder if they have higher levels of LP little a that would tie into the warrior lipoprotein, so to say, right? I don't know.
Yeah, it's a big mystery. I only know that it's very genetically driven, so it's just one of those things that if you're unlucky enough that you have it, you just have it, and it's just almost completely genetically driven. But why it exists, I would love to know the answer, but I don't.
It is malleable, so I've got to put that out there because I've had values. I've tracked it, I think, 35 times in the past 10 years, and more, even more recently. I've had values as high as 145 nanomolar and values as low as 70 nanomolar, and even more recently. But if you took the average of all the tests, 90 nanomolar. But more recently, because I'm tracking it so often and I'm tracking diet in conjunction, I've been able to cut it from 90 to 70 nanomolar. Now, can I cut it to 15 nanomolar? I don't know, probably not. But there's probably going to be a genetically lower limit that I can get to where other biomarkers don't start to go out of whack, whether it's glucose or HbA1c, which then also raises this conundrum of if I go keto, I could probably because higher fat in my case, and I'm not keto, it's hard to be keto and eat 85 grams of fiber, but there is some aspect of higher fat in my diet where if I increase it, LP little a comes down. But then on the other side of that, the higher my fat intake goes, now glucose and HbA1c go up. So I'm making variables that can make it. So there's going to be that U shape for the bottom of them, which then ties into this idea of precision nutrition, right? How can you optimize risk across the spectrum? And what is the dietary composition to do that? But there's no published data on this, but it is malleable. It's just I disagree with the idea that I've heard of, measure it once and forget about it. I think that's flawed.
Well, there has been recent publication, and I actually wrote the editorial to this publication on the question of variability because LP measurement variability has been observed and quite substantially. But there was a recent publication by Florian Cronenberg and others that really dug into this question, and they went through excruciating efforts to minimize technical variability. Let's put it like that. So there is for sure technical variability. The only question is the measurement variability that has been observed, is that technical variability source or is it biological variability? And the answer seemed to be very much technical. So the technical variability question, if you measure Lp(a) repeatedly, you will get some variation for sure. But probably most of that variation is due to technical sources. So the biological variability, underlying biological variability is probably very small. But then you mentioned also diet. There are types of dietary intervention studies where you do see some effect. I don't want to overstate this effect. It's, something can be statistically significant, but not really clinically relevant. And I think this is one of those cases. So as you allude to, if you consume high levels of saturated fatty acids, your Lp(a) may go down paradoxically
while increasing LDL.
Yeah, so that's one of these things that is curious, and I sure do not have the answer to the mechanism behind that. I don't think anyone knows that. But would you want to go trade that? Well, if you don't experience the LDL increase and you have a Lp(a) decrease, sure, that's could be a good thing. But I would also say that it would probably be a quite substantial Lp(a) decrease to make a clinically meaningful difference. And you run the risk of course, increasing your LDL, which would more than offset that little risk reduction.
But if ApoB stays the same, and if you've cut LP little a and increased LDL within that equation, then technically your atherogenic risk should be lower, right? So
yeah, technically, yes. The only question is that how big can you achieve that, and how big is like how much can you rearrange your ApoB composition? I would say that if you lower the best way to lower risk weight ApoB is just to lower everything. So trading particles for each other, I think that's a more, at this point in time, it's a more theoretical reasoning, but pragmatically lower than your risk weight ApoB will go down.
definitely. So I hear you on the technical variability, but so if you've got data and say you've got, so in my case, 30 tests and the average is 90 nanomolar, and now I've got 3 tests, 70, 72, 69 nanomolar. It's hard to say that would be technical variability when I've got 30 tests, literally 30 data points at a higher number. And now all of a sudden there could be technical variability, right? But with enough data, with enough testing, you can get around. Every biomarker has some CV, right? So if you measure enough and track it over time, then you can kind of get around that hurdle. But even with one measurement for sure, is it an actual representation of one's, you don't have a CV for them, right? It's just one data point.
And I would also add that what probably you are doing, maybe you are actually doing something that can make a dent in Lp(a). I would say that the studies on technical versus biological variability, those are just in regular free living individuals. Of course, they're not doing anything special. So within that context, maybe technical variability is,
Right.
yes, it is the dominant factor, and it's the dominant factor for 99% of the population. But if you're one of those weird guys who does something very, very, very special dietary wise, maybe you actually find something that could clinically relevantly lower it. So I'm open to that, and that would be very interesting to study.
Yeah, HDL. So you had a nice discussion on HDL and why you didn't include HDL, because you mentioned lipoprotein related risk, but where's HDL? So it's in the supplementary data, but you wanna explain that for people who don't know?
Yeah, so one of the first thing, if you include HDL cholesterol or ApoA1 in the model, you do include sex, gender by proxy, because women tend to have higher HDL cholesterol. So prediction model wise, the model will sort of guess, that's probably a woman, and women have lower cardiovascular risk, and then you will improve your risk stratification. So it will falsely boost your prediction accuracy. The real question is that we do not want to include non-causal risk factors in this type of model, risk-weighted ApoB equation. We could, if we wanted to include age or sex, we could have done that and boost the concordance index statistics, but we chose not to do that. And the other reason for it, there's a big discussion on HDL as a risk marker, and I do think it has value. It may have value in being sort of an HbA1c, but for triglyceride-rich lipoprotein exposure. I can explain that a little bit better. But if you have, we know from randomized control trials of, for example, triglyceride lowering, if you lower triglyceride lipoproteins by inhibiting ApoC3, what happens is that you causally lower your triglyceride lipoprotein levels, and you causally increase your HDL cholesterol levels. And plasma triglycerides and TRL cholesterol, to some extent, are these noisy little day-to-day fluctuation variation kind of thing. Your plasma TG in the morning can be different from in the evening, and so on. So it's a noisy measure. But underlying that, you have the HDL cholesterol, which is more throughout the day stable measure. And if you have a high triglyceride-rich lipoprotein exposure, you can capture that accumulated exposure perhaps in HDL cholesterol. So HDL cholesterol in itself can actually be a good predictor of cardiovascular events and may add to the actual prediction capacity of the triglyceride component in the model. But it is, however, not established as a causal risk factor. So that's the reason why we did not want to include HDL in that model. As I said earlier, you can probably create 10 different versions of risk-weighted ApoB that serves 10 different purposes, but we specifically wanted to serve this purpose here.
Got it. That's great. All right. So current and future studies?
Well, I alluded to it in my slides. I think the residual risk identification aspect or capability of risk-weighted ApoB is something worth exploring. As I said, if you're in a situation where you're taking a statin, you're lowering your LDL, you're lowering your ApoB and non-HDL-C as measures may break down a little bit in that particular context. So that's no good, because that's exactly the kind of context where we want to be able to identify remaining lipid-associated risk as accurately as possible. So we have ongoing discussions on getting access to data to test that, to test risk-weighted ApoB in that context. And we're also doing work in several other cohorts and to test risk-weighted ApoB in different clinical contexts, so in different ethnicities, different men and women separately, high, low age, high, low BMI, high, low blood pressure, and so on and so on. So in different kind of clinical contexts, and we're in the midst of writing up a little bit of a meta-analysis on that as we speak.
So is it can you give us a early scoop if people have made it this far in the video?
Yeah, sure. Yeah, you deserve it. You deserve an early scoop if you're still with us. So yeah, I mean, it is in virtually any context, it does seem to outperform ApoB. That's the early scoop.
Nice. All right. Well, thanks, Elias. That was great. I'm looking forward to seeing that published and more work from your group. Is there anything we didn't cover that we should cover in lipoproteins and lipidology and cardiovascular disease?
Well, that's a big question. I can speak hours on ApoB contained lipoproteins. So we'll take a rain check and open up for new topics in the future. But I think we covered plenty during this session.
Fantastic. All right. Thanks, Elias. Have a great day.
Thank you.